Okay, Brady, that's a good one. There is one of the things is to try to find out what the expectation is from a standpoint of when somebody comes into the visit, certain type of things that come in that would be an issue. Rebecca, I'm assuming that that's the question that you're talking about. So another thing would be is to get a feel for maybe what the household situation is. This may be important, especially some of the questions that we may need, and we may come around to those again. Would be, for example, the individuals that may have um, uh, concerns with regard to caregiving. If you're dealing with a lot of stress or you're dealing with something like that, one of the issues might be from a standpoint of maybe the environment has created a lot of, somebody's mother-in-law has moved in or something, or they've moved in with the family. So finding out, finding out sometime who's actually in the household, that's a big issue there. The other issue that sometimes is that we actually, this is something that I just really found out. I mean, teaching pharmacy students for all these years, and one of the things we've had to address in the past couple of years is that we are finding that we have students that are impoverished, that going to pharmacy school but are impoverished, and some of them we actually have had one or two students that literally are homeless, and that's been. And I've had some graduate students in the past. One of the concerns we've had sometimes is we do know that they have no place to go, especially between semesters and things like that. That can create a problem there too. Jordan, you bring up another point is basically what actually has, if something's been going on, what is it that really prompted you to come in now versus if they've been talking about the condition or something going on for some time. Sometimes you can get that information from a standpoint of maybe some symptom has gotten worse. And we're seeing that there. Another issue, Angela, is any recent life changes, and that may be including with them, but it also may include with, maybe their significant others or somebody that's close. That can also be an issue there too. So these are all things that may give us clues of not only what's going on, but also may give us clues from a standpoint of the success of choosing or using a particular treatment modality. So that's a thing there. So what we need to do is basically is to get these initial questions, and these initial questions, again, we want to be putting in our mind we're starting to strategize, if you will, as we're listening to these questions. Basically, sometimes the way the person is explaining, you can find out someone that goes into a lot of detail. That may be the main thing that's bothering them. Some things that they may not provide a lot of detail, but may be a significant issue that may suggest that they're having some difficulty. So, again, the thing I really want to emphasize down here is at the very bottom of this slide here, went back, is that there really is no one way or single best way to these are the little glitches here that are so there is no single way that is to interview a patient. You will and one thing that you need to be aware of is sometimes you can get what you feel like is your best way, which you're the most comfortable with, and that may work for a lot of the patients. But on the other hand, you got to realize that there may be one or more patients that'll come up that you have to change your way, which sometimes puts people in a little bit more of a, out of their comfort zone, which is your comfort zone. All right. Now, let's go to the next one. So the follow-up questions that we're going to get, and some of you guys have alluded to them, and one of the questions today was, why are you seeking services, now? Because one of the things we want to know is how long, what they come in with their chief complaint. We want to know, okay, so how long has this been going on? One of the key points that sometimes we forget, it's a very obvious question, is sometimes is that have you had a similar problem in the past? We tend to, sometimes even with medications, we're like, have you taken this before? One of the things we want to know about, because somebody comes in and having a really weird reaction, one of the things that may happen is we may be concerned with regard to have they ever taken this medication before? Sometimes they may not know that because if someone else is managing their medications. The other thing is sometimes the individual with other conditions, some of the things y'all are dealing with, they may not be aware that they've had the problem or may not be aware of what they were doing. Someone else may have noted it, but now it's become a problem. We also want to move to the next group of questions, such as pretty much how much does it bother you? You may get differences depending on, gender. You may get differences on culture. For example, sometimes an individual that is a male may not want to indicate, it may appear to be like a weakness if this is something that's bothering them. An older person may sometimes feel like that if this is coming up, maybe they're there because someone else has prompted them to come, their sibling or somebody like that. But what you need to do is that maybe they're afraid to tell you or say that it's been occurring or that it is really bothersome because they're afraid that's going to put, added pressure on who they're staying with, or the person would, that would be too much of a bother and the person would want to get rid of them. Sometimes the aspect of it is they don't want to tell you as a clinician because they don't want to be a bother to you, or maybe they're intimidated with it. And so these are things that sometimes we run into things sometimes that, for example, with some of our foreign students, graduate students, and is that they will have things that are going on. I dealt with a student, which eventually, I think this was about 3 years ago, we eventually had sent him back to India. But what was happening, he was going through severe depression. When he had some separation anxiety from his family. He already had some underlying depression. And one of the things was we were finding this out indirectly because he was afraid that we would kick him out of school if he if we knew about his depression. And the point was we weren't going to kick him out of school, and we had to work with him. But the reality of it is that his depression had moved so far along that and gotten worse that basically what we had to do is assure him that we were not kicking him out of school, but we really had to have him take we gave him the option of a medical leave of absence. Now, he never came back to our program, but he went for a long time. Not only was he being depressed, but one of the other students was telling us he wasn't eating. He was getting some nutrition issues, fatigued, and so forth. And so he would do, like, for example, when people were starting to get concerned about him not eating, when he would show up in the department, he would have food like he was going to eat it, but he just never would eat it. He would sometimes even spread it out to try to cover that up. So one of the things is that we need to find out how bothersome it is to their problem. Another big concern, this is one of the things that we run into sometimes, is people in the military, people in the police. Sometimes they are concerned, especially about mental illness, because of this could result in them being potentially discharged. I know that I've dealt with a couple of people that was a major concern, is that they did not want to be on an antidepressant because they didn't have to really, they could see clinicians and see something, but they would always be very careful they would try to hide anything was there, and they would not take any medications. I don't know if you guys have dealt with that or not from a standpoint. So one of the things that you may be fighting is that a concern with either the patient or even the significant other with regard to that. That's a good one too, is pilots. Pilots are a big concern there. So that's so we do have occupations. One of the things that I dealt with just recently is an individual who was a a truck driver. And the interesting thing about this was with a diabetes. This was a guy that basically, if he had to, the situation was if he had to take insulin, injectable insulin, depending on the state, the different states had different issues. So one of the states, if he was diabetic and had to take insulin, one of the states that he was driving in said that he had to have, I think it was 6 months to a year, where that he was monitored closely with no hypoglycemia, no instances or whatever. His biggest issue was his current route went across states with 3 different regulations. And what we were able to do is we were able to work with him to where his route was changed, where he only drove in one state, so he didn't have to worry about going across state lines and dealing with that. So these are other things that come into problem, and it sort of relates to the next question is, does it interfere with daily activities? And the question is, how much? The daily activities, one of the big ones is it interfere with driving? That's probably a big concern. People may not be able to carry their, go to work, may not be able to take their kids into school or take care of their parents, drive to the doctors. Another thing is that with the daily activities, this can include, hygiene. It can include a number of different other things. And so sometimes the interference may mean that the caregiver may have a bigger issue because the caregiver may not feel they have time to take care of this, or that the caregiver, one of the things we run into sometimes is the caregiver basically would have to give up their job in order to take care of that. One of the things is also, does it interfere with sleep? You may find that when we talk about sleep, interfering with sleep, they may not be able to sleep during the evening or at night, but what they may do is they may take multiple naps during the day. They may be sleepy, which may affect their job performance. So this is often a big issue. And patients sometimes don't understand that for healing, your body does need rest. And so a lot of them say, well, I'm not sleeping well, but it still can come in here. We're going to talk about objective and subjective data today, but one of the things is on some cases, you guys are familiar, is we may ask them to rate the problem. Let's take a pain scale, for example. So if we're asking somebody to rate the problem, with 1 being it's almost, hardly any pain, just a little bothersome, to 10, which is the worst pain that they've ever experienced. What's the problem with a scale like this, using scales like this? And I'm using pain just as an example of one. I think most people are familiar with that. There's a lot of subjectivity to it, right? And Brady bring up a thing is also the symptom magnification that can occur. So one of the things becomes is that everybody has a different feeling. So if I'm telling you to rate the worst pain you've ever felt, for example, you might have somebody that's passing a kidney stone. You may have somebody with severe gallbladder disease, severe bone pain. Those are definitely 10s. But if you've got somebody that the worst pain they've ever felt is, let's say they pinch their finger in the door, that's a 10 to them. But that's a big difference between somebody that may have, severe bone pain, or as one person that I knew of used to have showers of kidney stones. I'd never heard of that before. But they literally referred to it as showers, where that he would be passing 5 to 10 stones at a time over a period of time. So when you rate the problem, you've got to be careful because it's a very subjective scales when you give this. When they are, is it anything like you've experienced in the past? When you talk about symptom magnification, I remember when my daughter Allison was going to a pain clinic, We sat in there one time, and we were new patients. I was sitting next to her, and there was a lady sitting next to Allison, and asked her if it was her first time. And Allison said, "Yes, ma'am." And she said, "Well, here's the secret." She goes, "They're going to ask you, how severe the pain is on a scale from 1 to 10. And this lady, and I'm sitting there, and this lady told my daughter, she said, "So if you want to get the same pain meds that you're getting, then you tell them it's got to be between a 5 and a 7. Because if you go under 5, this is what she's telling with her experience. If you go under 5, they're going to try to lower your pain medications. But if you want to get more medications and a higher dose, then you got to be at least an 8 to 10. She said a lot of times they're not going to believe it's a 10, so an 8 and 9 is a good schedule. So basically, that is an issue. Janelle, you bring up another good point, is that the patient's answer with regard to their level of functioning can be off. So one of the things that may happen is a patient may provide a higher rating or a more severe rating because it would interfere. Like, for example, when my dad was, when he was diagnosed with cancer, one of the things to him was very important that he could drive. We told him he couldn't drive. My dad, when he was left alone, would get his keys. He would hide keys, and he would get up and he would drive to the McDonald's, which was about 2 miles from his house. And it was sort of like his way of proving. So although he would have a high pain scale and all the other stuff would be high, as far as his functioning, his driving was there. We ultimately came down to, as long as he had his keys or he could see his keys, he didn't have to drive. But taking it away from him, it was almost like he would, just to defy you, go ahead and drive. So sometimes there may not be an issue that's there. Talking, another point is secondary gain. What does it get them? Either a different medication may get them some other modality which they want, may get them attention. Those are things that come into play. So this is part of the things you guys have already gotten that thing. Another big point there is disability ratings. There are individuals who don't want to be disabled and will actually go the opposite way, which will underestimate because they have the possibility. But we see more frequently as somebody wants to. I have seen more and more disability tags coming out, and I'm seeing in this area, in the Atlanta area, that it is that a lot of doctors give those disability tags out frequently. All right, so let's go to the next slide. Okay, another thing is this may not be affecting you guys as much from a standpoint of it, but from a standpoint of symptoms. Now, some of the symptoms that you guys may be looking at for either drug effects or whatever could potentially be this, but when they're giving us a symptom, we need to know things like, is it specific to an area or to a specific time? Like my wife has some gastroparesis going on, and we're trying to figure out what's maybe triggering it. So I'm constantly asking her, for example, this is how long after you ate does this occur? What did you eat? So and the different types of the nausea is part of it, but also some abdominal pain. We have a friend that has been having some abdominal pain, and we think she's got probably a PID. So being able to know where the pain is, this is also going to be important to you where these symptoms are, because when you go to do a physical assessment, one of the things that you need to be aware of, if you are having to touch or probe or assess a particular area, knowing where the symptom is and knowing where it may move or how it may go will tell you to be cautious. So, for example, if someone comes in and tells me they're extremely nauseous and they've had some diarrhea, and I'm doing an abdominal exam on them and I start pushing down on their abdomen, one, it could be very painful for them, which could potentially, I don't know if any of you guys have had this happen, but you can have people reflexly react to that pain. They can be guarded, which they tend to pull back from it. But the other thing is, if you hit a sore area, sometimes people just lash out. I've talked to several residents that they're assessing something and they push down too hard after the person said it hurts, and that person has kicked them or slugged them. We want to know if it changes over time, just like with many of the symptoms that you may be looking at. we're trying to identify where this is occurring, how it occurs, what goes over time, what may precipitate it. If we don't have a localized symptom, we may want to determine whether the symptom seems to radiate. Does it start from one place? Does it then progress out? Does it just seem to be, we do have some people, sometimes it'll just be a very intense pain in a very focal or localized area. A big thing is going to be, has there been any therapeutic modalities tried on this? Now, we're using the term therapeutic modalities, but when you're talking to a patient, you may want to, when I went through this with the pharmacy students, we were watching them counsel patients, and sure enough, we had a few of them, person is sitting there, person is very sort of intimidated, and the individual, our student goes, what therapeutic modalities have you used? Well, that patient had no idea what a therapeutic modality was. We changed it to, what do you do that may help? What do you do that didn't work? So when you're looking at therapeutic modalities, what does that include? What are we going to include with therapeutic modalities? Okay, medications, especially looking for evident past medications. That's a good one, Janelle, is what have you tried that has tried to improve the condition? What has worked? Anything. Sometimes it can be moving. Sometimes it can be just, exercise. Sometimes it may be a hot bath. Sometimes it may be, ice. If we're looking at a friend, we may see people that. Counseling is an issue. When you're looking at medications, make sure you ask about OTC. Make sure you ask about supplements. But here's one that you may want to find out. So all of the things you guys are putting down is exactly what that is. Depending on what you may be looking at, you might you may not have to go through everything. For example, some of them may tell you that exercise may help, and others may say exercise makes it worse. One of the things, though, that when you're getting this information, sometimes patients may be nervous about, we do see a lot of patients that may have been trying someone else's medication. Another thing for you guys to be aware of is sometimes the patient may not have tried the medication particularly, but they may have seen an ad, or their friend may have told them that this works really good for them. And if they tell you medications, one of the things that you want to be cognizant of is that if they tell you medications that it appears that has not been prescribed to them, that usually means they are borrowing medications, or someone has offered to give that, or offered to try it. And I just dealt with a case 6 months ago where a guy had chronic pain, and he was taking medications, and the question was, I was like, well, who's been writing your prescriptions? Well, he didn't have insurance, and so what he was doing was he had a friend who did have insurance. So his friend was going to the doctor and telling the doctor he had a bad back. The friend had a bad back. The friend was getting the medications and then was selling him actually oxycodone for like $20 to $40 a pill. And he said his friend helped him out by doing that. And his friend was basically making some good money and was doing insurance fraud and all this other stuff. But one of the things is that you may want to find out if there's things in their medications and you're trying to find out who prescribed them, because sometimes you may be finding out they're taking someone else's medication. That's a good point too, Eddie, is that we want to make sure that the person has been taking the meds, and not only have they been taking it, but are they taking it the way they should be? So we do have some individuals, I'm using pain management, pain is a good example, that they will not take it like they're supposed to take it, but would hold it and wait till the pain gets bad and then take more of it. And so that's another important thing, is to have the patient potentially tell you how they're taking that medication to see if they are taking it correctly. Another thing is patient may sometimes not know exactly when this occurred or may not want to tell you, but we want to know is that has the symptoms gotten any better or worse? They stayed the same. Um, if they started getting worse, I mean, some of the things that you guys will be treating, definitely you want to look at maybe what circumstances may have exacerbated it. Dealing with depression or some of these other things, you may find that it may be due to some stressor that's come in that's there. The other thing is that sometimes we want to know what the associated symptoms are. These may not be the dominant problem. These may be, the patient may come in. For example, if we're looking at depression, the person may come in and is not coming in because they're depressed. They may be coming in because they can't sleep or they're really tired. And so one of the things that we want to do is try to find out. So they come in and tell us that they are not sleeping or that they're tired. We want to try to find out if they're, we want to find out what else would we want to, what other associated symptoms, for example, that might be there that you would want to ask about, say if a person is depressed. Can't focus. Okay. Janelle, I'm going to say you're depressed because I just read how you spelled difficult focusing. So, and suicidal ideation. So we just have diagnosed you based upon your typing there. Difficult focusing. One of the things may happen would be, another thing may be is job performance suffering. In school, if they're not focusing. What's some other things, say for depression? Weight gain or loss, exactly. A lot of people think when you're depressed, basically you're going to lose weight, but we see a lot of people put on weight. Changes in appetite, okay? Energy level going down. Either can't sleep or is sleeping too much. So those are, all of these things are things that could be there, and these would be related problems, some of which the patient may not necessarily be aware of that they're associated with this. And so it may be some questions that you could ask, for example, on their appetite. You can simply ask them from a standpoint of have you been eating? And if you ask that question, that's so open-ended in one sense, it's like, well, yeah, I'm eating. Obviously I'm not eating, but the point would be is that maybe they're eating, but maybe they're not eating regularly. They may, instead of eating 3 meals a day, they may only be eating like 1 meal, or nibbling on something during the day. On the other hand, they may be packing it in. The other thing we run into sometimes is individuals may use when they're eating, may eat a lot of sweets, to sort of give them energy, and then so that can affect their sleep and so forth. So those are things that we want to try to get out there too. Another thing is asking the patient, what do you think the problem is? What do you think may be causing this? That's a big thing. We just got a phone call from a friend of ours that's had some issues, and the point is that they have one symptom, and the problem is that their mind is now going. We talked about this a little bit yesterday, from a standpoint of they've got on Google, or they've got sat down. Don't overlook the fact that Google is probably the most common thing, but another thing can be the local person in the nursing home or the local person in the neighborhood who seems to have the answer to everything and has made the diagnosis for you too. So the thing about it is, we see people all the time. It's like, oh yeah, I had an aunt that had these same type of symptoms and she died like in 3 months. Well, what was the symptom? Well, she was nauseous all the time, or she was, she was constipated all the time. And you're going, the biggest one we saw was that we saw something like that where the person said, oh yeah, she got a lot of diarrhea and then she got constipated and they found out she had stomach cancer and she died like 2 months after they diagnosed it. So the patient may have that in the back of their mind. Patient may have also been reluctant to come to see you anyway, because one of the things is that they were afraid of what the diagnosis is going to be. Okay. I mean, about a year and a half ago, I had a toothache. I suspected it was under a crown. I suspected that it was an abscess, and I kept watching it and watching it. And it was like flare up and go away every time it flare up. And then it got to the point where I couldn't stand. I mean, the pain was horrible. And I just told my wife, I said, call your dentist. We were changing dentists at the time. I said, get me into your dentist. And they went and saw me, and the guy said, no, you've got an abscess. So you're going to have a root canal. And so I went to get the root canal. And the point is all the whole time I was afraid it was going to have a tooth pulled. I ended up having a root canal, and it's doing fine. So, but the thing is, I knew what it was. I mean, there was no question in my mind. I knew what it was. The point is even as educated and everything that I am, is I just didn't want to deal with it. So I kept thinking, well, maybe it'll get better. And a lot of people do that. I'm not going to ask any of you to raise your hands or to indicate that you would do the same thing. All right. The other thing sort of gets back to a question that one of you put up here too, or as a question is we want to know what the patient's concept is. Has the patient, do they have a perception of how important this thing is that they're showing up for? But the other thing is we really need to know sort of, we can be fighting a battle with a patient that has an agenda for this patient-provider encounter that may be different from us trying to treat this patient. A good example would be that somebody that has an addiction problem is wanting their agenda is to get pain management or to get a narcotic or to get a benzodiazepine. But their overall issue is they're not wanting to treat the addiction. So have any of you had patients that that you've picked up other than a drug addiction issue that have come in with a specific agenda for the encounter that may not have been what you all had? What are some examples of that? One of you mentioned, the person's coming in, they want the disability. They're not caring about anything else. They just want the disability thing. What else? What would be some other things? Wanting an ADD diagnosis. Shelby, that's a good one. Is basically the prison situation, letters, pain medications, diverting meds. These are all issues there. All right, let's go to another thing. What about especially with situations? There you go. That was one of them, Jason. I was looking at is part of this may be an issue to address a legal problem like a divorce. Therapy dogs. That's too. I just was reading something about where this was getting to be a big issue is the therapy dogs and sport animals. Let's see. Well, there was one other I was just thinking of. What about let's go to the other end with geriatric patients. Is someone brings it in because maybe someone wants either you to make a recommendation that a parent or an older person needs to be institutionalized. Another thing may be is we've seen them come in sometimes, whether to have them declared whether they're competent or not, maybe for some legal or financial issues. Another issue would be is that we've seen let's say an older parent is living with the individuals and is becoming very demanding. So they don't want to put them in a home yet, but they don't want to have to deal with them all day long. So what they do is they bring them in, and what they're really wanting you to do is to basically medicate them up so that they won't wander around. Pretty much that, the old days they would use Thorazine. So the aspect of it would be, well, give me some Thorazine. The Thorazine, mom or dad will just be sleeping over in the corner. I don't have to worry or mess with them, during the day, and I can get things done. So there's a lot of different things there, and especially when you get a caregiver situation coming in, this can be a big issue. All right. So actually, let's see. We're going to come back to this in just a moment, because what I'm going to do is we're going to use this with a break. So let's do a couple more slides, and then what we're going to do is I'm going to have you come up with a list of questions based upon this this scenario that we have here, and so you guys can do that in just a minute. But let's cover, let me see. Yeah, let's cover a couple more things, and then we're going to give you that sort of little exercise to do on the previous slide, and we'll give you about 5 minutes or so to do that and take a little bit longer break. So when we're doing an interview is what you should be doing is, and you probably are doing it, and you may not be thinking about it. So as you're getting this patient history, what you should be doing is actually, as the person is telling you things, one of the things that should be happening is that your brain should sort of be thinking, okay, this symptom gives me this, and so this could possibly be this. When they give you something else, I may be able to say this may be this, or the combination of those. So you should be, as you're taking that history, start thinking of pretty much a generation of differential diagnoses, which will be guided based upon not only your questions, but also the patient's answers to the questions. So you're actually in your mind sort of doing an algorithm. And let me mention this thing about the algorithm right now. The point becomes that everybody wants algorithms, so that it's like, if I get this symptom, I can go there. The problem is medicine, and this includes psychology, and you guys, I think, can appreciate this, is the problem is that algorithms, if we could do everything by algorithms, then pretty much we don't need your training. We don't need your training. But medicine is more of an art. It's a science and an art. And part of that art, just like I believe psychology is, that the part of that art is being able to have insight to, because all these patients are differently. And so, yes, in some sense, you are going to use some algorithms. But even with drug therapy, there will be times when there may be an algorithm that says, if this occurs, use this drug. But you may have a patient that you can't use that drug because of a comorbidity. So you got to keep in mind that as you are gaining this information, that it's basically a generation of differential diagnoses. One of the things that's very important is that we have to differentiate between symptoms that require urgent assessment and those that don't. For example, somebody coming in with chest pain versus nausea. But you could have somebody, what if somebody comes in and they are severely nauseous and vomiting, that would move that to a higher level. So one of the things is that although the patient comes in, the patient's primary goal is going to be what's bothering him the most, or the patient's caregiver, which may not be the most important thing to take care of. We may see some more. And so we're going to have to, as we're doing this, differentiate between the symptoms that require urgent assessment and that's those that don't, okay? Some symptoms, basically, we are really not sure what's going on. I mean, these symptoms are somewhat ambiguous. And we basically, those symptoms may emerge, and we may actually have to have them play out until we see a recognizable clinical entity. It just depends on the components there, and we just have to be aware of it. Okay? I'm going to cover this one, then we're going to take our break. I'm going to give you your homework to take on your break here. One of the things is that when you're doing the interview, I don't care how much you've done it, it is when you're doing this, there's probably with different patients different levels of discomfort. So what you got to think about is you may be uncomfortable with getting some of the questions, although you may have gotten to the state of what I call the clinical mode, where you sort of isolate yourself and it's sort of like you're really just sort of not thinking so much. You're really thinking so much more of, I need to get these answers and I've just got to sort of put my emotions out of it. But in general, and this is one of the things we tell especially new patients, you guys, many of you have got much more experience. I said new patients, new clinicians. But typically is when you're going in there, you've got a person that's potentially sick. And almost everyone is going to feel uncomfortable, not necessarily with every patient. Some patients are easier to deal with, some are not. Some easy patients with the diagnosis that you start seeing may make you uncomfortable because you see where it's going. The process is intrusive, okay? We are asking for the patient to give us personal information. We are asking the patient to provide information which is, we don't know if it is going to, if we're going to be able to completely help the problem, and we don't know where the problem may necessarily go and get. but the patient is exposed. We're asking some very personal questions with the patients. And these questions typically are in depth. There's follow-up questions that make it even more in depth. Sometimes the questions we're asking are very intimate with the patient. And we, depending on what our relationship is, when you first walk in on a new patient, there is no established relationship. Even sometimes when you walk in and the patient is someone that you know, you may not have established that relationship, on the level that you're going to go to. But we have to be aware that there are questions that we may ask this patient, which we may be uncomfortable asking them, but we have to have the answer. We need to know the answer. And we also have to consider that they feel uncomfortable because of that. Yesterday we talked about just the way you ask the patient and so forth. Sometimes humor can help a little bit. Sometimes humor is not the best thing. So that's the skill that you have to learn. And this is what I was talking about. When you've done this for a long time, I call it clinical mode, is there's a tendency to become complacent as you gain more experience because it becomes sort of a job, okay? So it's very easy to become immune to the sense that you're invading their personal space. In fact, sometimes I've seen clinicians that the problem is that they actually get angry and make it even worse because it's like, I'm trying to help you and you're not trying to help me. And I wouldn't be asking these questions if I didn't need them to know them. You'll have a patient sometimes that comes back and says, why do you need to know that? Or I'm not going to answer that. Or as we said yesterday, the patient lies to you and he's lying to you. No, he or she is lying to you. So the point is that those, and sometimes it's very difficult. I had a situation where a mother called me and they had gone to, she'd gone with a checkup with their teenage daughter, and the clinician was talking to her about the HPV vaccine. And the mother was basically saying she doesn't need that. And she, the mother, here the parent and the mom, the parent and the teenager sitting there, and the mom wanted to know why the HPV vaccine. The clinician sort of told him, and she said, well, my daughter's not sexually active. Well, I pretty much know her daughter is sexually active. And she was asking me why they were pushing for the HPV vaccine. So sometimes some of this information gets to be very difficult, and you can get complacent and forget about what it's like to be, the patient from that standpoint. Okay. Anybody have other comment about just this provider discomfort? Anything, observations you guys have seen? Sometimes when a patient comes in and you ask very intimate questions, this barriers between you and, becoming across as just the person demand, it's almost like that you don't have any compassion can sometimes be an issue. You guys have also even a harder job because many of the patients that you're going to deal with can be, they can form a bond with you that may not be the type of bond or they may be forming a bond with you, the bond you may not want. We see a lot of OBGYNs that run into problems with the patients because when they're, the patients give birth, that's a very intimate moment with the doctor. And we see a lot of patients sometimes fall in love with their, OBGYNs. All right. So we're going to take a breath. So patient comes into you, and the patient, and we'll just leave this up, and you guys are going to go for your break. So we'll come back at 15 after the hour. So basically what happens is patient comes in and tells you, about a month ago, I started feeling chest pain. Okay. You could get this question from some of your patients. So the thing I want you to do is just make a list of questions that you would follow up with. Okay. And just have those ready so that we can go over those when we get back from break. So what we'll do is we'll take our first morning break, and I will see you guys at quarter after the hour. Let's make that 20 after the hour because we're almost on the hour as it is now. And I'm going to go to mute. All right, guys, we're back, and several of you have put your questions on. You did a pretty good job with it here, so let's just look through here. And again, let's see. So the things is that we've got a person comes in a month ago, started feeling chest pain. What questions do you follow up? All right, so here we've got a concern here because chest pain could be a number of things, and many of you touched on it. But just to look in, I'm going to go through it. So questions that you want to know is, how often does it occur? How do you rate the pain? Does the pain change over time? Looking at what Janelle had written, have you had it in the past or anything similar? How is it affecting you? A big question, like for Angela, is basically, is a good one here is what makes it get worse? What makes it get better? Any history? Najib, it's a good one there is that, basically, is there any family history of heart disease? Do you take non-steroidal anti-inflammatories? The NSAIDs could come into play with either maybe potentially an ulcer. And some NSAIDs have suggested, in the past, some of the NSAIDs it could actually cause a heart attack. So most of you, let's see, any strenuous activity. Is it one thing? Is it intermittent? Does it come and go? Does it? How long does it last when it occurs? Nina's got some things. This is a history of anxiety or panic attacks. Current meds. Any cardiovascular disease. When you eat, does it make it happen? Sometimes when you eat, does it make it? Does it seem to make it subside? Some ulcers we talked about last semester. Remember, some ulcers make it get better. Some worsen pain. Some makes it better. So one of the things most of you've got main things there. Getting his history. One of the big things that you want to do, first of all, if it's pain and he looks in distress, tell him to get to the hospital. If somebody calls you, even the cardiologist will tell if you call your cardiologist, say I'm having chest pain, they're going to tell you to go to the hospital. And a lot of cardiologists will tell you they've sent a lot of people that have had indigestion to the hospital, but it's better than waiting around. Some people will try to wait around and do that. So you guys did a good job with regard to getting these questions. Some of this information you may actually have because you may already have pull the guy's chart up or seen his chart and see what his background is. And so if you knew he had a history of heart attacks or whatever, or whether it was a male or female, I didn't tell you with regard to that. All right. So that was, you guys did a great job with that. Think about as you got those questions, I think as your questions were being developed, you were thinking about what conditions. So if we looked at, and Maribel, that's a good point too, is another issue is it could be drugs. We are seeing much more younger people going to the ER with chest pains because of meth or cocaine or some of these stimulants. All right. Let's go on. Let's see. There we go. All right. So these others, we can move through these next slides a little bit quicker because of most of you have done, have already been doing medical records as you practice. So, first of all, with past medical history, sometimes we get a problem with this because a person may not remember. Sometimes a person may not want to give you past medical history. But if you ask them, do you have any medical problems? How do we do this now? I'm just curious, of all you guys, how many of you actually ask past medical history, actually ask them that? Or how many of you basically have a chart they fill out and they just go through and check all of those different boxes that you have? Does anybody, okay, Maribel, you ask. Anybody else ask or you do both? Okay. Okay. What you see a lot of clinicians doing is what they will do is they'll have the chart filled out. And of course, one of the things that is sort of interesting now, more and more practices now, when you're going to see a new clinician, everything goes online. I was talking to somebody yesterday that was filling out the papers for a new clinician, and they were talking that there was that the new paperwork was close to 20 pages. It's great, Janelle, that yours will auto-populate for medical providers if they're on the system and so forth. That takes a lot of time. But, you know, one of the things that happens sometimes is individuals, I know that my family physician, I was talking to him, he has iPads, and all of the things are on the, or it's not an iPad, it's similar to an iPad. And it's mainly checks and boxes, very little writing. Actually, it's no writing, it's typing in. And he was asking me what I thought about it when I went in to see him a couple of years ago. And I said, I thought it was interesting. I said, my curiosity is that how well is this being accepted by the geriatric patients? He sees a lot of geriatric patients. He said, actually, it's being accepted really well. A lot of them have difficulty seeing, and a lot of them have difficulty writing because of tremors and things like that. And so his statement was, you know, with doing the iPad, he said a lot of times, you know, somebody younger comes in, sometimes even the grandkids, and they can help them run through it. But a lot of the older people like that because it's automated and they can increase the size of the font. And of course, populates it right into his database, which is good. He doesn't have to worry about transcribing there. But a lot of times what we see is that a lot of people will have the forms filled out. And then what you basically do is they'll look through, and anything that's positive, they may ask questions on. But the other thing that may happen is seeing the patient, knowing a little bit about the patient. For example, sometimes a person may be on a medication, but not really know what they're on the medication. And so sometimes by looking at the medications, you may modify that. If they aren't really sure, a lot of times you can ask questions like, you know, have you ever gone to the doctor before? If you did, you know, what was it for? Are you under the care of a physician now? Are you seeing somebody on a regular basis, or do you just go in when you are, you know, get sick or have a problem? Any procedures? I will tell you these, you know, a lot of procedures. I think most people have had x-rays, and we have a lot of people, but a lot of the people may not know whether it's a CAT scan or an MRI. You know, they really don't know what that is, but that can get it. Ask them if they've ever been in the hospital. Some of them would say no if they've never been hospitalized, stayed overnight, but you may have had several of them several patients may have been to the hospital for, you know, showed up for the ER room. And again, if it's like sprained ankle, potential broken bone, cut or something like that, that may not be quite as important unless you're seeing a pattern, which then it might tell us, for example, we have an older person that is continually being hospitalized because they're falling, or we have somebody that's been going to the hospital because their glucose is not being managed. They've had those type of things, or maybe had seizures. Then we're dealing with something on a bigger scale. Past surgical history. Many times people may not remember when they were children if they've had anything. But if we do get sometimes this can give us some insight. Were there any complications with the surgery? A lot of times they may not know exactly what the operation was. I mean, for example, they may know that, you know, they may not know that it was a particular procedure, but they may know what it was done. I had my gallbladder taken out, or you know, my appendix removed, or something like that. Certain surgeries or things may not be readily apparent, although I'm seeing less and less of that being an issue. But things like breast augmentation or breast reduction, vasectomies, sometimes even facelifts and things like those are hysterectomies are sometimes there that jumped there. So sometimes they may not be as they may not readily to reveal those type of surgeries when you're doing a physical exam. you might come across a scar that would suggest there was a surgery or injury or something there, and then they can, you can inquire about that if you need to. All right, this is a big one, and this is one that it's really important that you get good information from. You want to know, are they taking any prescription medications? That's pretty straightforward. So questions, not only do you want to know that, but you also want to know, how often they are taking them, how long they've been on them. We want to know what the prescription is for. Was given an answer, or given us an example. I think it was yesterday, is like with a imipramine. One of the things may be is that do we know that it's used for incontinence, or do we know it's used as an antidepressant? There's a lot of off-label use, and so that can create some problems. It can create problems from the standpoint that you may think that this is a particular drug and it's being used for one thing, for its on-label use, but it may be being used off-label for something else. One of the things that's helpful is to find out if they actually know what the prescription is for. A lot of times a person, for example, may not know that a diuretic is being given to help their blood pressure, but they may be aware that it's a water pill. Okay. Sometimes with some of the mental health medications, they really may not know what they're for. In fact, one of the things that happens, just like one of the staff people was asking me, I shared with you yesterday, when she went and looked up, she was being treated for depression, and they had given her an antipsychotic, which we know there are things that are used for there. So one of the things that we found is that she was concerned that she had psychosis. That was one of the issues when she first looked it up, or she was being treated for being psychotic or psychosis because it was an antipsychotic. And so it actually was, when she looked it up on Google, it listed it as an antipsychotic. And then her doctor did explain to her that it was an antidepressant. Sometimes individuals have been given the drug and been taking it for a long time, and they really don't know what it's for. A doctor may have just simply forgot to discontinue that. And so another big point is that, are they compliant? So how can we tell, what are we going to do? How can we determine whether somebody's compliant? Okay. One thing is simply ask them, you taking your meds? The PCPs can sometimes run a medication report on certain drugs, not all drugs. What else? We can do labs. We can look at refills. We can ask for their pharmacy records. One of the things that, we tell the pharmacists is that if you've got a regular patient coming in and as you pull up their chart, you may find that they may be refilling one meds versus another. On the refills, what we want to really do is we want to make sure that that they're being done on a regular basis. So for example, with something on chronically, I would have concerns. So for example, let's say that the person is getting refills, but let's say the person is getting the refills, but is only using it, part of the time. So we do have patients that will go get their refills on a regular basis, but are not taking their meds. Here's another thing that can happen, especially with non-controlled substances, but antipsychotics, antidepressants, definitely this can occur is, let's say that a doctor writes a prescription for an antidepressant, and let's say they're at 10 milligrams. The doctor writes a prescription for 10 milligrams for this medication and writes them for 3 months or even 6 months. Patient's coming in, and the next thing we know is after about a month of this, the doctor changes the patient's medication to 20 milligrams. So he writes a prescription for 6 months for 20 milligrams. So now the patient may actually be getting both medications. Like for example, some of the pharmacies may have filled a 90 days prescription And so the person may have 90 days of one prescription. Then he gets a new prescription. And so when the refill comes up, it's possible that the patient may be taking both meds. So taking 30 milligrams, a 10 and a 20, or it may be possible the patient goes ahead and gets it and just sort of hangs on to it in cases they need it. These are things that are there. If you can, Jason, that is a very good point too, is one of the things is that if you're not seeing any abatement of symptoms, they're not responding. Either they're not responding to the drug, so the drug's not working, or they're not taking it. So that might be one of the things. But what you have to be careful about is if the person is taking it erratically, one of the things that you got to be concerned about is that whether you change the drugs or you change the dosage because you think it's not working, and then the patient decides to take the new med, and the new dosage or the new drug may produce a big problem there. So that's something we want to be aware of. Monica, the thing is we like to have the patients bring in the medications to see exactly what they have, and we'd like to see. In fact, we do some of these things called a brown bag thing for some organizations where we'll take some pharmacy students and we'll go to like a nursing home or something like that, and the people will bring their meds to like a little luncheon, and then our students will take them all out and go over the meds and not only counsel them about their meds, but also look at to see, for example, you got one that's 30 days and it's 28 days, you should only have a couple of pills in there. But Kirsten, that's another thing we do see is we do see a lot of individuals that basically for a lot of things, we even are seeing sometimes that we've seen antidepressants in particular, or some of the psychotropic drugs being taken only when the person, quote, feels bad. And the other thing you can do is you can actually tell them, how do you take this medicine? So take the bottle and you're looking at it and you're going, okay, this is your blood pressure medication, or this is your anxiety medication. Tell me how you take it. There was actually a study done, I think back in 2012, where they basically took college-aged adults, and what they did was they gave them a prescription, and they asked the person to read the prescription label and tell them how they would take the medication. And so they did that, and the majority of the individuals were able to do that correctly. But interestingly, they took that same group and they gave them another prescription, and they told them to actually act as if they were taking the medicine. In other words, pour out the pills like you were going to take it and when you would take it and so forth. And what they saw, again, this was a group that was able to tell the person how the medication was supposed to be taken based upon the label. When they actually went to do it, a good percentage of them were not able to do that. Which is very interesting. So if they're not compliant, I think I've given you guys some examples too in the past, is you could have somebody that's supposed to take medication 3 times a day, and that individual is taking it 3 times a day, or is taking 3 pills a day, but they're taking them all at one time. So they may just take them all in the morning, so instead of spreading them out. Or we may find that they are, we got to be careful about them breaking up tablets, breaking up things. So we really need to be cautious with that. Some people will have may have a difficult time swallowing capsules or swallowing tablets. And so it may be that we may have to look at alternative ways, because we typically tell people if it's anything that has extended release, so if it's an XR, XL, CR, any of those type of things, we tell them they can't be broken up. We tell them that we typically will tell them that if it can be broken, it's usually scored. But even with scored tablets, we may see people that basically, when they go to break a tablet, we've seen individuals, for example, that will take a butcher knife to try to break the tablet, And what happens is part of the tablet goes shooting off the counter, and the dog catches it midair, or they can't get it, can't find it. So the person may not do that. Sometimes the individual, we've got a pill cutter and broken up the tablets for individuals. So these are all things that are there that can come into play. And some people will just say, well, I got to take it twice. I'm just going to take a whole tablet this morning rather than trying to break it, and take half a tablet this morning, half a tablet in the afternoon. Monica, you said you've had some success about the Amazon pill pack. That's, and anything we can do to sort of help these patients to do this and be compliant, we try to. The pharmacist can often give you some good things, and we tell them to do that. If the patient's not compliant, we need to find out why. Older people sometimes will spread out their medications to save money. So what they will do is, instead of taking it, if they got a tablet they're supposed to take once a day, they'll take maybe every other day or every 3 days. So we have to be there. We need to know what over-the-counter medications they're taking, how often, what the dose is, why are they taking it, does it appear to be effective? You see some people that say, I'm not sure it's effective or not, but I'm just going to, keep taking it because I'm not sure. Some of these over-the-counter things can actually, and even supplements can sometimes be prescribed. The doctor, even though it's doesn't require a prescription, the doctor sometimes will write a script so that the patient can remember to take it. And sometimes the individuals may actually get it filled because their insurance will pay for it if it's a prescription. But over-the-counter supplements, one of the things with the supplements is that, for example, if someone says, well, I'm taking St. John's wort. Well, one of the problems that comes in is that when you look at St. John's wort, and I don't know, I haven't looked back closely. We did some research on this several years ago, but we saw some St. John's worts that were standardized to one component in St. John's wort and another that was standardized to another component. But also people might decide to buy wherever they can get it the cheapest. And one of the things that we may see is that a different manufacturer may have a different, there may be different constituents in there. So one of the things that could happen, and even this is with over-the-counter and it can happen with generics, is if someone is lactose intolerant, one brand may have lactose in it, another brand may not. Or if they have gluten allergies, we may see gluten in one and not the other. That could affect it. But with the supplements, we have some patients that take supplements all the time, and they get one supplement, same brand, get at the same time. Those usually are less of a problem, but we do see people that they get whatever's on sale. So this different supplements from different manufacturers may contain different things. The other thing is the FDA does have a website. On the FDA website, you can look up recalled supplements, which will list supplements that have had problems, and sometimes those supplements have stayed on the market or people have bought them and are not aware of it. So that's one thing that you might check. And then the other thing we do see, and we're seeing more and more of this now, is non-traditional medicine. So non-traditional medicine, and we could even include homeopathics in this too. These can have could have potential impact on what you're seeing. And so it's important for you to find out exactly what they're taking. On some of the homeopathics, you may find the way that they're dosed is a lot different, and what their quote dose is expressed differently, and you may have to get someone to help you interpret that. There's a lot of homeopathic people that are around that can do that. But our biggest problem is, for example, we see our Chinese students here in Athens. We've had a lot of the Chinese students that actually bring their folk remedies and folk medicines over here, which they have a name for it, but we don't really know what's necessarily in it. So these are all things that can occur. And sometimes it's a question like, for example, the homeopathic stuff is that we don't have, and even with supplements, there has not been a lot of research done on drug interactions with prescriptions and so forth. We're starting to get some of that information out. But for example, many years, for many years, people that were being treated for AIDS, many of those patients would use a lot of supplements, one of which was like St. John's wort. And it wasn't until just a few years ago that we discovered that St. John's wort actually interferes with the antiviral actions of some of the AIDS drugs. So sometimes these patients, people give them stuff and they don't really know what they're taking. That creates problems. Somebody will have a home remedy or have a tablet or something, says, oh, I use these and here's some, try them. And then the person is taking them, but we may have a hard time identifying them. Every prescription drug has an NDC code, National Drug Code on it. So you should be able to go to these pill finders and identify and be able to put in what it's there. But some supplements and some of these non-traditional medications, we don't know what they are. So we may not know what's in them. The person that's taking them can tell you sort of what's in them, possibly, but many times they will just say that this is, this is such and such. And some of my Korean students have even talked about there's a big difference between ginger and the ginger root, depending on where you get it, which part of the country, and that sort of thing, that there can be differences there. So these are all important issues that have to be considered when we're considering this. Okay, so here's one of your questions. All right, so if you guys will just answer on the whiteboard thing there. So suggestions for keeping up with medications include A, carrying a list of all meds, B, bring the meds to every visit, C, call a family member, D, take a pic of the meds, E, all of the above. This one is one of those questions. It was very difficult to write a question without sort of giving the answer out. But let's go through each of these really quickly to just point out things. There are still a lot of people that that they carry a list of their meds. They either type it, have somebody type it up, or they basically handwrite it. Sometimes these little things that you can put on the back of your phone that holds credit cards or stuff like that, some people will actually stick that in it or have it in their purse. The biggest thing with them carrying a list of their meds is sometimes the list of meds, they don't update them, or they just list the med. They don't give a dose or things like that. So what I used to do is I used to tell people that when they're writing the meds down is to write down, basically the name of the med, how often there's, what the instructions are, how many times per day, and all that other stuff. Janelle, you're right. The B is very good. And on the meds, I also tell them I need to know if you're taking any, over-the-counter supplements. Write those down. Sometimes with the meds, the problem is that the individuals just keep adding to their med list. So one of the questions you get is a big med list, but you don't know if they are currently taking those. There may be some meds that they've been discontinued or whatever, so that's an issue. Also, carrying that list with them being folded several times, sometimes it gets to be sort of ratty and very difficult to read. Sometimes we will have patients that will bring all their meds like in a baggie and their supplements and everything, and I really like that when we do get it, because you can pretty much look at it and you've got the label, especially some of the over-the-counter and supplements. That works really well. But Janelle, as you said, it's typically not very practical, especially if someone has got a whole lot of meds. But I do see there are some people that are taking a lot of meds and they have a DOP kit and they just put all their meds in there and you just sit there and have to go through them. Calling a family member can work sometimes, assuming that family member, sometimes they're trying to go off memory. Sometimes they may not know everything the person has taken. That's probably not the best way. D works pretty well. This is one of the things that you can have them just take a picture of each bottle. Now, the biggest thing they have to realize is sometimes they will take, and I've had attorneys send me pictures of bottles, and the problem is if they don't get a good picture, I have a picture of a pill bottle and may not get I may get a partial name for the drug. The main thing is usually I will get the drug, but I may not be able to get what the exact dose was or anything like that. But the pick of the meds, you know, or the other thing they do is they take a group shot. So it's very difficult to really discern what all is going on there. What actually works a little bit better is sometimes if they can get their pharmacy records they need to bring with them. That may not include supplements and some of these other things, or may not include medications that are somebody else's that they've been using. I have had people that have taken pictures of the individual tablets or capsules. That is difficult because now I have to sit down and try to determine, you know, what each of those things are. But if they can get their pharmacy records, that does work pretty good. And they can even take a picture of the pharmacy records. Now, what we've done sometimes is we have to realize when they give you a pick, you may have to download that pick so you can expand it, and that can work sometimes. But all of these are ways of doing it, and especially with somebody that's got a very complicated, a lot of meds going around, these are good things for you to have. And the nurses, I know that when I've gone in with one of my family members or something and been able to simply, you know, pull those up and hand it to the nurse or to the doctor has worked really well. Okay. So getting back to what we were talking about is you need to, one of the things that you can do is encourage your patients to, or the caregivers to have a medication list that is kept current. Another thing which I tell people is to encourage using a single pharmacy. That helps a lot because the pharmacist will be keeping that, and the pharmacy can simply print off those. And also by the person doing that, one of the things that can happen is that the pharmacist is more likely to pick up drug interactions because they know all of the meds are going through them. So that's a good self-check. Many people do that, but not everybody does it. So it's one of the things to be aware of. As we mentioned, bring meds to the visit. Sometimes the point is I may suggest to them to bring their supplements to their visit and just give me a list of the meds. The supplements tend to be the ones that are more difficult or that you need to run down. That's an issue. And then using a smartphone to keep a list. Now, if they're, you know, one of the things that can happen is that you get a lot of different pictures. It may be very confusing as to which is the current list or which, if they've got everything in there. But these are a couple of things that will help quite a bit. Now, a big issue is going to be determine if anybody has allergies. So one of the things you find is individuals' concept of what is an allergy can vary greatly. So we want to ask, do they have any adverse reactions to meds? Okay. Sometimes you will have people say, well, I take this med and it gives me diarrhea. And, you know, something like erythromycin, which is a common antibiotic, can do that. So if they have had any adverse reactions to any meds, what we want to know is if we can get a nature of the reaction. In other words, what happened? Did you break out in hives? Did you start itching? Did you, you know, have to go to the hospital because it was so severe? So we need to try to do that. One of the big things we find is what, you know, for example, if they had a reaction and they stopped the meds, did the reaction go away? That's called a de-challenge. But then they took the med again and it reoccurred. So that's a re-challenge. So this can be very, very insightful because you would expect that the drug was causing this reaction is that when you give them the med, they get this action. If you stop taking the meds, it goes away. But if you gave it to them again, basically it should occur again. Okay. So the re-challenge, if that has occurred, or de-challenge, that can be very informative with regard to whether it's actually the medicine causing the particular reaction. So along that way, here's your next question. If a drug allergy is suspected, it should be confirmed with a challenge, de-challenge, re-challenge. Challenge is you give it, de-challenge is stop it, and then give it again. So true or false? Okay. this is the response I sort of expected here. So the reality of it is, it depends. So if I'm looking at somebody that I'm thinking the drug may be, you know, that they break out a little bit in hives, I might decide to do that, to do it. But your statements, Janelle and Eddie, was basically what you need is it depends on the reaction. So if the person basically goes into anaphylaxis, then I'm not going to re-challenge that person. I'm just going to say it's a drug reaction and this can be life-threatening. Somebody's allergic to penicillin, then basically that has a reaction, I'm not going to wait till it clears up and then try penicillin again. So it really depends on how dangerous the allergy is. I mean, from a standpoint of science, that would be very informative to us and would give us insight as to whether the drug actually was causing it. But in the name of ethics, if the reaction was life-threatening or potentially life-threatening, I would not want to do that. So again, sometimes we've had instances where individuals inadvertently have been re-challenged, and we have that information there. But again, if an allergist was wanting to do that to try to determine it, they may do it. But typically, if we know it's a reaction, a potentially life-threatening reaction could ensue, no, we don't want to do that because of there. So would it confirm it? Yes, probably one of the best ways to confirm it. Can we do it in every reaction? Absolutely not, from a standpoint of ethics. See if that's better, Arnold. I readjusted the microphone. Does that sound any better? Okay. All right, good. All right. We're going to take this one, then we will take a break, our last break for this morning before we go to lunch. So with smoking, we always want to know there's smoking. A couple of things, reason we want to do it in just a moment. But one is, are you a smoker or non-smoker? One of the things we may ask is, instead of smoker, we may ask if they use tobacco. Because there are people that don't smoke but chew snuff, and also vaping is a new concept. So, but if they do smoke, we want to know, you know, how much they've used. So, how long you've been smoking, how many years, and we actually usually put this in pack years, packs per day per year. So, for example, we would how many packs do you smoke per day, and how long you've been smoking? You know, we realize that some people may smoke typically a pack per day, but in some days they may smoke a pack and a half. Another day they may smoke, you know, maybe half a pack. But that gives us a form. And really, what we're looking at is an idea of the other forms of nicotine. You know, are they chewing nicotine gum? Are they have they quit? Are they in the process of trying to quit? But also, you know, snuff, chewing tobacco. These are things that in my grandparents' days, a lot of women didn't smoke. A lot of older women didn't smoke. When you get to the elderly women, they would not smoke. They would more frequently use snuff up in the hills of Virginia and Tennessee and so forth. Now we got vaping, so that's another question. So some people would say, I don't smoke, and that would be the answer is I don't, but they may be vaping. And if they've quit, when did they quit? We still would like to know, get an estimate of how much exposure to smoke they had in the past, if they can give us an estimate on that. But one of the reasons we want to know about smoking is, it can be a health related issue. So if they're smoking, this could be producing, you know, some deleterious effects on them. And two is, smoking can sometimes affect certain enzymes. And we'll point those out to you next semester. So that's another reason why we want to know about smoking. And so let's take our break. Let's come back at 5 after the hour, and then we'll pick back up. I'm going to go to mute here, and I'm going to be flipping through a couple of slides. So if you guys see the slides moving, it's not because I've kicked back on, but we'll start back at 5 after the hour. Okay, guys, we're going to pick back up, and we'll go to the next slide. Is the with regard to alcohol use, we want to know, do they drink, how much per day, and uh, preferably what type of drink. One of the things that we run into is we keep in mind that when we are looking at drinking, is going back to I don't know if I talked to you all about a standard drink, but when we're looking at I don't think I did. I think possibly Dr. Norton will talk about this. But for example, what we consider as a standard drink is we typically will look at it as a 12-ounce beer with normal alcohol content, typically between 4 to 7%, 1.5 ounces of spirits, or potentially about 4 ounces of wine. But when people say they drink, one of the problems that happens is their concept or what their perception is with regard to drinking. One drink is a drink. So if someone is drinking an 18-ounce beer, that's one beer. If someone is, drinking something that's 100 proof, that's big difference, because the spirits we usually are looking at 80 proof. Some of the wines are fortified, so there can be. So when we ask them about what type of drink, somebody might say, "Well, I have a shot of whiskey." Well, we're making an assumption that that's like 80 proof and so forth. So it's sometimes, and I've seen this for many, many years looking at med charts, is when people give you their drinking, a lot of times it's underestimates. And secondly, we see often that we don't really know 12 drinks, may have 4 drinks per day. What do you mean by 4 drinks? And there's a big difference between having, 4 drinks spread. Like, for example, I was dealing with a legal case right now where the guy said he had a bad accident, hurt somebody, and his blood alcohol is up above, point, I think it's around 0.13. And he told the officer that he had a beer about 30 minutes before, but he had had 5 beers earlier that day, starting at about 5 o'clock. So the accident occurred around 11:30. So if he had 5 beers since about 5 o'clock, drinking over the period of time, with the last one occurring, 30 minutes before the accident, drinking the last 30 minutes of the accident, you would expect his blood alcohol to be probably between 0.02 or 0.03 at the ultimate. Well, there's no way that drinking over that period, he's going to do it. Now, if he drank 5 beers with the last one being finished up right before the accident, in other words, he had knocked down, 5 beers about an hour before hour and a half before the accident, then his blood alcohol is going to be much, much higher. So that's going to be, how much per day and type of drink. So I did have an 80-year-old guy that came up that was typically drinking 3 to 4 bottles of wine, and his liver enzymes were elevated. He didn't understand why. And I said, I think it may be the wine. So some people will, tell them, we've had doctors that have actually prescribed the person to have a glass of wine, and that seems to be okay, unless the person is going to take maybe some Ambien that night. So the combination can create. That's a thing. So the chart on the wall is not a bad idea. But a lot of craft beers and things like that can have much higher alcohol concentrate. A lot of people, they don't drink on a daily basis. They may consume this, maybe a couple of times during the month, or maybe once or twice a week, but still there's a big difference. You need to know how much they drink, because there's a big difference, sort of what Janelle has put there that we're talking about. If the person doesn't drink all during the week and only drinks occasionally on the weekends, is what they tell you. What you may find out is what they do is they may be knocking down, a 12-pack. So they may be doing binge drinking on the weekend, which can have a pretty significant health problem. And so we do see that sometimes people they say they drink occasionally, and occasionally may simply be that they're putting away quite a bit of alcohol. And then some of them occasionally they have a beer every now and then. So we need to get it. It's not uncommon to have in medical records different perceptions. Sometimes a spouse or caregiver may give a different concept than a than the patient. Oops. And then other drug use. This one tends to be one that a lot of times the individuals may either lie to you or may not give you. And then we do have some that are individuals. Again, remember when we did lab tests, I gave you some things about alcohol, and I told you, or potential signs of drug abuse that were not diagnostic, but stood for potential signs. So what we find is basically for this other drug use is a lot of times we can't just determine by general appearance. Okay, there could be some potential indicators. For example, their pupils. If the pupils are extremely dilated or extremely constricted, wearing down of the teeth or the teeth in very bad. We see that a lot with meth. The presence of injection sites on the arms or track marks or infected injection sites. What we're doing, and it's important for the patient to know that, is we're not judging the patient. We're basically trying to identify risk factors that may be involved, that may account for some of the things that the individual is doing, or may have an impact on not only their other health issues, but also on potentially what medications or treatment modalities that we're going to recommend. Obstetric issues. Have they ever been pregnant? If so, how many times? What was the outcome of the pregnancy? Was it full-term delivery? Was it spontaneous abortion? Was it a therapeutic abortion? Was it, C-section? Those are informations. One of the questions is, are they pregnant now? That could potentially, are they trying to get pregnant? Those are issues that are important. And this is another area with which can become very uncomfortable. Is a lot of practitioners don't even like to ask this. It can become very uncomfortable for the patient. One question is, are you sexually active? Are you in a stable relationship? It's important for us to know what type of birth control you're using. One of the reasons is some medications that we may be trying may put a risk to the fetus, and we want to make sure that you're on an adequate form of birth control. Another thing can be is birth control can affect hormones, obviously. We may have potential drug interactions. For example, there are certain drugs that we may prescribe. You guys wouldn't prescribe that, but may be prescribed by clinicians. Some of the antifungal agents could inhibit the interaction of some of these oral contraceptives. Actually, some of the drugs that you might prescribe, such as some of the enzyme inducers, I think Tegretol is one, which may increase the metabolism of the oral contraceptive and make it less effective. Are they married? Have they had any history of past sexual transmitted diseases? These are also in this aspect, you can also inquire as to, the significant other. What's the health of the significant other? What's the health of the children? If they have any children, these can give you some information of maybe some stressors. It can also potentially give you some indication of potential diseases that potentially may be transmitted. And then family history, it's not important that we have them go back to their great grandparents. Really what we're looking at is the first or second degree relatives. So what we're looking at is the issues of their siblings and their parents. Grandparents is, if we get the grandparents, the parents, and their siblings, then it's pretty good there. Anything that's going to show up in those, there's going to be more. It doesn't mean that there may be some sort of thing that's inherited from way further back that they may get there, but typically the most prominent things are going to be what you get from your grandparents or your parents. And so one of the things, like for example with heart disease, is we do know that's inheritable, and we do know that if you've had a grandparent or parent that has had a heart attack before the age of 50, that puts you at a high risk, especially if you're a male. In my family, my brother had a heart attack when he was in his 50s, which means that in my family that males are at a higher risk for heart attacks. if they've had any family illnesses, when did they occur? I mean, we don't need to know the exact day and month that it occurred, but we can, a lot of times, knowing, for example, that when my brother was 55, he had a heart attack. That's the type of thing that we want to know. What it may do is it does have us take a look at specifically, to be aware that you may be at a risk for that disease. Also, one of the things that can be very helpful sometimes is that if some of these diseases have been in your family and they've been treated for them, that may give us insight with regard to which drug to start off with. If a patient, if one of your family members have not done well on one drug, then we may want to avoid that drug and start with something else. If they've done well on another drug, let's start with that. So that can give us some important insight with regard to our treatment modality. The work, hobbies, and other things, the occupational history, one can, there's a couple of things that happens by asking about works and hobbies and stuff like that. Number one is it does improve communication, helps establish a rapport. The person feels like you are interested in what they do, especially with their work or the hobbies. Knowing whether they enjoy their job, whether it's a drudgery, could give you some insight as to things that may be affecting them, what hobbies or sports they're involved in, where they came from. Sometimes there are certain diseases that are inherent from certain parts of the countries or certain parts of the world. So these questions may or may not provide us some information with regard to their health. But one of the things may be, for example, with their job, we may find out that they're being exposed to, for example, if they worked in a dry cleaning establishment, we may learn that they're being exposed to organic chemicals. We may learn, something about their nature of their job may give us some indication of possibly what some of the problems are. But again, one of the best things with these line of questioning here really comes down to it helps establish communication. It helps break some of these barriers down. The patient actually feels interested in what you're doing. Think about, you walk in and a clinician basically says, why are you here? What's your symptoms? Okay. And then writes your script, hands you, and you're gone. Now, some of us might be like, that's all I need. I don't have to spend a long time. But especially if it's something sensitive or something like that, it may be something where that an individual, feels more comfortable and will give you the information and actually will help with the therapy because they feel like that you're vested in there. Giving them or getting them involved with their own therapy is something that we've learned, which in many years ago, there was it was almost like clinicians felt like patients were too stupid and they just need to do what we say. So that's an important thing to actually get the patient engaged and potentially help you. The other thing is, like we've alluded to already, is that sometimes a patient may not mention a particular health problem, but they may say they're on medications or they may give you some other clue. So for example, if they're taking an antihypertensive, you might suspect that they have high blood pressure. If you were then going to take their blood pressure, you would be looking to see specifically, was their blood pressure high? If they're taking drugs like nitroglycerin, then that might be a situation where that, they possibly had a heart attack or had angina. So certain drugs that they may have on their medication history or recurring where they've had episodic periods of drugs, you may find they're susceptible to a prescription or susceptible to a particular condition. And so when you do see that, simple follow-up questions are going to be, I noticed that you're taking this medication here. How long have you been on it? What are you taking it for? Is it helping? Those type of questions seem to work pretty well. All right. So that gets us to, we've just about timed this pretty well. So we're at the vital signs. Okay. So we're going to spend some time this afternoon on vital signs. So when we look at vital signs, what we consider vital signs are typically temperature, body temperature, respiratory rate, your pulse, blood pressure. Your pulse is giving you basically your heart rate. And then we even include blood oxygen saturation or oximetry. So these are what we're going to consider the vital signs. And this is, from the rest this afternoon, as well as next time we meet, you're going to be taking some of these vital signs. So those of you that have done vital signs before, you're going to be in good shape. Those of you that haven't, use this as a learning time for this. Those of you that have taken it before, just brush up and see if there's anything you can do. So we're going to do that. So why do we take these vital signs? Is because they do or can provide very critical information about the general state of health of the person. Sometimes they can identify the existence of an acute medical problem. So for example, maybe the person is fainting and we realize their blood pressure is too low. They can sometimes give us, they do give us some impact or information regarding the magnitude of an illness. Typically, the sicker the person is, the more deranged or the more off their vital signs are going to be. And also they can give us some index of a chronic disease state like hypertension. So these are pretty standard for most individuals. You know, when you go to the doctor, pretty much they're going to take your blood pressure, your pulse, and your temperature. Those are going to be right there, those three. And then now docs have been sometimes taking pulse oximetry. The pulse oximetry is, they have those available. You may want to get some pulse oximeters to use for your patients. But these are, you know, fairly easy to take with a little bit of training. Now, we're going to do these next 3 slides, and then I've got a video link, which Marissa, I've already sent to you. If you can do that. Edie, the issue is the automated blood pressure machines are good, but you do need to learn the manual, because if your automated machines go down or you don't have them, you need to know how to take the other one. Okay. So if someone else has already taken, a lot of docs will have their nurse or a technician take your blood. Then if you're going to base your therapy on this, or you have concerns, the vitals don't look right, basically you should take them also. That doesn't always occur, but there are patients where you look at a vital and it just doesn't seem to jive. Maybe it's out of sync with what you've had before from that patient, or the patient doesn't seem to be exhibiting, you know, some of the signs that the vitals would most likely do. So if someone else has taken them, it's not bad to, especially if you're going to base your therapy, you know, for example, if I want to make sure that the person doesn't have a tachyarrhythmia or their heart rate's going too fast, and I'm going to give them a drug that may speed up their heart, I may want to take their heart, you know, pulse rate again. There is a significant potential for error with taking vital signs. There is a number of ways that error can occur. One, just by not paying attention and not listening. Another thing is probably most of the things is where someone's just not paying attention to it. So we will, every now and then, there could be equipment error. So for example, your blood pressure cuff something may be wrong, or the gauge may be off. So there is a lot of potential for error. They're easy enough to do, but sometimes the very easy things to do, the very relatively simplistic things, error can occur, and it can really mess things up. So we have to be aware of those, okay? When you take these vitals, in an ideal world, basically what we should see is that where you're going to take them, the exam room should be quiet, should be warm, well lit. It should be as comfortable as you can make it. Typically, we want the patient to have the opportunity to come in, sit down in the room, sit there approximately for 5 minutes, and we're going to take the measurements while the patient is seated. You know as well as I do that in a clinician's office, whether it's your own doctor's or even your office, that there's a lot of distractions. You're trying to move patients in and out. Sometimes those patients get pushed in and they don't have time to sit. You know, ideally what they would do is bring them back to the room, let them sit there for about 5 minutes. Then, you know, you come in and take their blood pressure measurements. Here we go. No consumption of alcohol, caffeine, tobacco, or vigorous exercise should occur within 30 minutes of the exam. Okay. We don't anticipate somebody coming in that's been drinking. Okay. So the alcohol is usually not a concern. Although if somebody came in and you smelled alcohol on their breath, or they just said, I just finished a cocktail, or just drank a beer out in my car while I ate my sandwich waiting to come here, that could affect your reading. The biggest thing you worry about probably is the last three: caffeine, tobacco. People come into the doctor's office with they've just smoked a cigarette outside, or they come in and they have their Starbucks coffee. They're sitting there drinking it in the waiting room. The vigorous exercise can be an issue where what if you're on the third floor and the elevator's not working, or the patient's impatient, and he runs up the floor. He's the first appointment after lunch. He walks in, everybody's ready, waiting for him, and they bring him right back. He sits down. He's just ran up 3 flights of stairs. Even if you're on the first floor, somebody parks their car running late for their thing, it's raining outside or whatever, and they dash across the parking lot to get to your office. So if they come in and they're sort of breathing heavily, or say, I've just ran in, they do need to sit down and relax and do that. Okay. It's great if that when you put them in the room, you can sort of observe the patient from sort of out of their way, out of their side, to the side of them, that you're not sitting there watching them, but just to see if they seem to be relaxed and see if there's anything that's occurring. Is the patient anxious? Sometimes we do have what is called white coat hypertension. So if the patient is worried that his blood pressure is elevated, or sometimes if he's worried about some of the questions you're going to ask, or why he's there, he or she is there, then that can raise their blood pressure. If the patient's in pain, patient may be wincing there, and when you go in the office, he doesn't do that, she doesn't do that. But if the patient is in any type of pain or seems to be upset or anxious, that can affect the vital signs. You want to look at their overall dress and hygiene. That can give you some insight. Next time we meet, I'm going to go through each of the systems, and we're going to talk about things that may be observations and so forth that may be indicative of some condition. Take a look at the patient's shoes. Are they tied? Are they worn on one side? Are they, is there something, are they on the right feet? This can possibly give you some insight into something else that's going on. So here's a question. So if someone walks in, you're going to take their blood pressure and heart rate, and they've just finished a big, maybe a monster drink. So would you expect the caffeine to do what to their blood pressure and what to their heart rate? Okay, so the answer you guys chose was C. So you would expect the caffeine to increase their blood pressure and increase their heart rate. Exactly. Okay. All right. We're going to stop my lecture here. So what I have for you guys is there's a link, and that link basically is a series of videos that I want you to we're going to go through. We're going to go through the various components. But from the standpoint of the link, this link, if you open the video, and I just checked the video a few moments ago from a standpoint of, I'm pulling it up here so I can sort of tell you what it is. So when you go to this video site, in my I've got 2 computers running here. There we go. So this is entitled, the video, or the website you go to is entitled The Introduction to Vital Signs, Examination and Evaluation, and it is a study guide for healthcare sciences. I think you'll find this as a good reference point. So it gives it's a module overview, gives an introduction, then it talks about body temperature, pulse rate, respiration rate, blood pressure. Okay, so if you look at it, basically it will talk about some of these things that's here, and it actually has a little video at the bottom, or a little slide set at the bottom that you can click through. And so what I want you to do is to look through that over lunch, and then we're going to talk about, and I'll have a couple other videos when we get to different things that I want you guys to look at as we finish up this afternoon. So go to those modules, and you'll see that for each one of those modules, you don't have to go through the introduction one, but you can go through and just click on the ones that basically says, body temperature, pulse rate, respiration, and blood pressure. And they're fairly short. And again, at the very bottom, there is a little slide set of anywhere from 1 to 18 slides that you can just click on real through and go through. So that sort of gives you an overview, and it's going to build on what I've got with these slides today for this afternoon. But all right, my goal is this afternoon is that we will get through where that y'all at least have had some exposure with the vital signs, and you're going to have more hands-on exposure the next weekend. So we will, so you take a look at that module, and we will start back again at 1 o'clock. Does anybody have any questions? Make sure you log out and then come back into the other log. All right. All right. So I'll see you guys at 1 o'clock. You guys have a great lunch.